Thank you, Bob. Good afternoon. It's a pleasure to be here with you in Vancouver. And I would first like to thank the organizers for inviting me to speak at this session and to update you on the Ipergay study. Okay. So first, my disclosures. As you know, PrEP trials in Europe and Canada have shown a high incidence of HIV infection in high-risk MSM, up to 9 per 100 person years. PROUD and Ipergay have demonstrated similar high effectiveness of PrEP with oral TDF-FTC in gay men, with point estimates of 86% relative reduction in HIV incidence. Ipergay is assessing coitally dependent PrEP in MSM who have frequent sex and use on average 4 pills per week, so about 15 pills per month. This slide shows you the sex-driven intermittent PrEP regimen that we used in Ipergay, and we instructed people to start with a loading dose of 2 pills, 2 to 24 hours before sex, then a third pill 24 hours later, and a fourth pill 48 hours after the first drug intake. So overall, 4 pills to cover 1 sexual intercourse. Following the results of the Ipergay study, a number of questions have been raised, and what I'm going to try to do over the next 10 minutes is to address some of the issues. One of the first issue is how early after starting PrEP were participants protected in the Ipergay study. If we go back to the macaque model data generated by Garcia-Lamo and colleagues, you could see that when they exposed macaques to rectal challenges with HIV recombinant virus every week, you could see that in the control animals in red, after the first 2 challenges, half of the animals became infected. Whereas in blue, in those who received a double dose of TDF and FTC before and after rectal challenges, these animals were protected to the 5th challenge, at which time one of the animals became infected. And if you look at the inserted panel, you could see that at the time of the infection, the concentration of tenofovir in the plasma of these animals, and FTC as well, were quite low. So these data would suggest that these animals were protected by PrEP pretty early on. And to support these data, when you look at tenofovir and FTC concentration in plasma and rectal tissue, rectal secretion in that case, what you could see in the left-hand side panel in blue is that tenofovir could be detected in rectal secretion only 24 hours after oral intake. Whereas in the right-hand side panel, when you look at FTC concentration in rectal secretion, FTC was detected as early as 2 hours after oral intake, and the concentration remained at a sustainable level up to 24 hours. Another piece of information comes from the cell PrEP trial, and these data have been published by Sharon Seifert and colleagues recently. In that study, they looked at the number of estimated daily dose of TDF-FTC that healthy volunteers were taking during a 30-day period to achieve tenofovir diphosphate concentration in PBMC at levels that have shown to be protective in the Ipergay trial. And what they have shown was that after 3 daily doses of TDF and FTC, you could achieve a 96% reduction in HIV risk, and this risk was even actually reduced by 99% after 5 daily doses, suggesting that pretty early on after drug intake, you can achieve a very high protection against HIV. What about the data in Ipergay? When we go back to the Kaplan-Meier plots of time to HIV infection in the study, and you look at the placebo arm in red, what you can see is that a couple of people have been infected very early on in the trial, with HIV infection detected as early as 1 month after they have started PrEP, suggesting that these people have been exposed to HIV in the couple of days following the initiation of PrEP, whereas when you look at the patients who were randomized to the TDF-FTC arm, you see that the people were protected, fully protected, until month 16, at a time at which some of the 2 people infected in this arm actually discontinued the use of PrEP. So these data would suggest also that with intermittent use of TDF and FTC in this study, the participants were protected very early against HIV acquisition. So to get more insight into the efficacy of PrEP in the Ipergay study, we performed actually a PK sub-study in 12 participants following a single double dose of oral TDF and FTC. And in those participants, we collected plasma, PBMC, dry blood spots, saliva, and rectal biopsies to do PK analysis and also to perform ex vivo HIV-1 challenges. Each participant in this PK sub-study at rectal biopsy collected both at the time of drug intake, so before drug intake, and then a second time point over the next 24 hours, with very early time point as early as half an hour after drug intake. The rectal biopsy were exposed overnight to a CC5 tropic virus and co-cultures with MT4R5 cells to detect HIV infection of these rectal biopsies. These data looked at actually the results of the detection of TDF and FTC in the rectal biopsies from these 12 individuals. And what's striking when you look at these data in green, looking at the concentration of FTC that you can achieve in these biopsies from these individuals, was that in green you can see that you achieve pretty high level of FTC in these biopsies very early on, as soon as half an hour after a single double dose of TDF and FTC. And this level remains sustained up to 24 hours. And you can see that in the control people who were actually HIV-infected participants who were on TDF and FTC for months, the level that you can achieve in the rectal biopsies as early as half an hour after drug intake up in the same range as those that you can see in people on treatment. On the other hand, if you look at the concentration of tenofovir in this rectal biopsy, you could see that you are not able to detect tenofovir until 24 hours after drug intake. And again, these data are consistent with the data that I've just shown you in the macaque model. What about the double dose we used with TDF and FTC? Is it associated with an increased PK exposure? To address this issue, I show you on this table data from HIV-infected patients who received either 100 or 200 milligram QD of FTC, and data we generated in the Ipergay study in participants who received 400 milligram QD of FTC. And what you can see here is a very nice dose proportional increase of FTC exposure, whether you look at the Cmax, the Cmean, or the AUC. And you have a twofold increase with 400 milligram as compared to 200 milligram, with the Tmax at 2 hours. What's also interesting in this table is to look at the concentration of FTC in the saliva, and you are able to reach pretty high concentration in saliva with a ratio of saliva to plasma concentration of 22%, consistent with previous studies we've done in HIV-infected individuals. With tenofovir, we've got a similar picture. When you compare data obtained in HIV-infected individuals, we were enrolled in a dose-ranging study from 75 milligram to up to 600 milligram QD, as compared to the data we obtained in our 12 volunteers in the Ipergay study. Again, there is a nice dose proportional increase in Cmax, AUC, when you increase the dose of tenofovir up to 600 milligram QD. And the data we've got in our participants were actually in the same range as those obtained in the HIV-infected individuals. And when you increase the dose from 300 to 600 milligram, you also increase the Cmax and the AUC. However, when you look at saliva, tenofovir penetrates very poorly in saliva, and the ratio of saliva to plasma concentration is below 10%. So again, there is a differential penetration of FTC and tenofovir in tissues. What about the post-exposure doses? Are they needed? Well, again, if you look at the macaque model data, you could see that when macaques were challenged rectally with a Shiv virus, but received tenofovir FTC before and after exposure by subcutaneous injection, it's the top line in brown, animals were fully protected. When you give the animals only the post-exposure dose in black, all animals became infected, so no protection at all, similar to the control animals. However, when you give only a pre-exposure dose, then you get only partial protection of the animals, suggesting that you need also the post-exposure doses to provide full protection. In our PK sub-study, we looked at the ex vivo HIV infection of rectal biopsy from these individuals. We were able to only analyze 10 participants who had rectal biopsies performed before and after drug intake. And what we were able to show was that before drug intake, all participants had at least one of the 4 biopsies, rectal biopsies, which were taken that could be infected with HIV. Whether after drug intake, only 6 of the 10 participants had at least one biopsy that could be infected, suggesting partial protection from this single double dose of TDF and MTC. Using another method to look at a rectal biopsy infection, a quantitative infectivity score, we see the same trend of the partial protection of the rectal biopsy from HIV infection after intake of a double dose of TDF and FTC. And if we look at the time at which the protection, this partial protection was seen, it was seen as early as half an hour after drug intake. But these data would suggest that in order to get full protection, you probably need also not only to have pre-exposure doses, but also post-exposure doses. So in conclusion, we could say that a double dose of tenofovir FTC is associated with a rapid and high concentration of tenofovir and FTC in plasma. Also, FTC can achieve rapid and high concentration in rectal tissue and saliva as early as half an hour after drug intake, which in some ways validate the regimen that we instructed people to take in Ipergay, in other words, taking the drug at least 2 hours before sexual exposure. Also, we feel like pre- and post-exposure doses both appear to be critical for providing full protection against HIV acquisition. One of the limitations of our study, because participants enrolled had actually a frequent sexual activity and used a quite significant number of pills, clearly the effectiveness of the creatinine dependent PrEP regimen that we have tested in Ipergay cannot be extrapolated to people who have less frequent sex at this point. However, we hope that the ongoing open-label Ipergay study, which probably will be conducted until June of next year, will provide additional information that might help us to address this issue. And I would like now to acknowledge all the participants again who made the study possible and those who participated to this PK sub-study, all people involved in the trial, in particular the PK group and the group that performed actually the HIV challenges of the rectal biopsies, and also the sponsor of the study, ENRS, but also the CTN, the Gates Foundation, the Pierre Berger, and SIDAction, and Gilead, who donated drugs for the trial. And with that, I thank you for your attention.